26-year-old Joseph Waititu, a resident of Utawala in Nairobi, spends most of his time trying to navigate the complexities that come with a cancer diagnosis. Waititu, who only got a definitive diagnosis of leukemia, a cancer of the blood, 13 months ago, is the poster child of the numerous barriers to achieving cancer care equity in Kenya, as the disease is not only causing him untold pain and suffering, but also impoverishing him to the high cost of managing it.
Ukisikia cancer unasikia tu ni kifo. Hakuna kitu kingine inakujanga kwa mind. Inakuwa hard sana. Nikaanza matibabu. My first cycle ikaenda vizuri. Phase 1 of UCAL. Hiyo ilikuwa chemotherapy. Then nika dischargewa. Nirudi after 2 weeks niende phase 2. One drug was costing 100,000. Na nilikuwa nafaa kupata 16 drugs. One cost 100,000, sina kitu, sina pesa. Sasa ikakuwa challenge, tukauza vitu, kitu chenye mtu alikuwa amejishikia, akauza.
Like many cancer patients who face tough choices about their care, the most gut-wrenching moment for Waititu was when he was forced to give up his independence and move in with relatives for care. At the same time, he had to quit working due to the side effects caused by chemotherapy treatment. For many patients like him, giving up one's sense of independence and quitting employment often creates a financial storm that devastates them and their families.
Imekuwa mzigo mkubwa sana. Kuna test nangoja kufanyiwa leo ili niende nayo clinic worth 16,000. Naweza kuambia sina. It is very hard juu hadi unaambiwa uende kufanya vipimo, unashindwa unaambiwa wazazi aje. Wameuza kila kitu. Hadi ukipigia mzazi tunasikia tu ni kulianalia. Amekopa kila mahali juu yako hadi unaona nikao umefika mwisho.
Whereas having medical insurance slashes how much patients owe for their care, cost sharing hits many like Waititu with bills that leave them reeling. Just like Waititu, Aaron Obuya from Kakamega County, whose wife also battles cancer, has felt firsthand the impact of the unpredictable cost of cancer care and access to medical services. And his predicament is made worse by the geographic remoteness of their home.
Hii mambo ya ugonjwa wa kansa imenitatiza sana kimfuko. Iliposhika huyu bibi yangu mwaka wa 2017, ilikaa tu kama ni alsas. So tulikuwa tunanunua tu madawa tukifikia na alsas ndio zimemshika. Lakini penye tumepitia kwa hospitali, tukianza na Bukura kwetu kwenyewe, nikampeleka Mwila, nikampeleka Butere, bas nikamleta hapa Kakamega. Nimeumia sana kimfuko.
Experts argue that addressing barriers to promoting cancer care equity is crucial in reducing the global burden and improving outcomes for people like Waititu, Mary, and the communities that end up shouldering the weight of managing their conditions.
Serikali inataka wasaidie wagonjwa wa kansa madawa, kwa sababu sasa hiyo inaleta shida sana ya kununua madawa. Vile unakuja hivi dawa hakuna, unaandikwa tuenda ununue.
Cancer remains a significant public health challenge globally, whereas the World Health Organization estimates that over 35 million new cancer cases will be reported globally in the year 2050, which is a 77% increase from the estimated 20 million cases in 2022. In Kenya, the annual incidence of cancer is 42,116, with 27,092 deaths, according to data by Globocan. Out of those 42,116 cases diagnosed every year in Kenya, 16,846 could be prevented and another one-third could be cured if detected early, according to experts. However, despite these alarming mortality rates, cancer still does not receive sufficient attention from policymakers and stakeholders in the medical ecosystem, and that is creating a structural and economic problem that is often transferred to the patients, their families and communities.
In low and middle income countries, in Kenya for example, in this region, out of 10 children who are diagnosed with cancer, only 3 will survive. I mean, those are statistics that we worry about. Only 3 out of 10. We don't, and maybe the 3 that can afford, to get comprehensive treatment all the way to the end, meaning that 7 out of 10 will die. If you look at countries in North America or Europe, out of 10, 8 will survive. Out of 10, 80% of their kids, the outcomes are so good. So why are we losing so many of them? Because of, again, financial access to care. Maybe there's also issues of low awareness about that children do get cancer. Even when they get cancer, are the referral systems, are they friendly to ensure that these children are channeled to the centers that have good cancer treatment facilities for the children?
David Makumi, who heads a cancer support trust in the country, is of the opinion that cancer care equity is essential in ensuring that everyone, regardless of their socioeconomic status or geographic location, has an equal opportunity to prevent, detect, and even receive appropriate care upon diagnosis.
There is also access to information, accurate information about cancer. Do they know where to go? What are the next steps? You have cancer. Do you know what will happen next? In terms of staging, tests, even how long will the cancer treatment will take. But importantly, access, financial access. Patients will want to know. They need to know. They must know how much is the cancer treatment going to cost, upfront. And that is one piece of information. When you talk even of access to information, that is a piece of information that is often lacking.
However, this is not often the case in the country.
Cancer is a silent killer that devastates families and communities, leaving behind a trail of pain and agony. And now, a combination of administrative and governance failures is making management of the condition an even more painful journey for patients diagnosed with the condition.
Despite the decentralization of cancer services to enhance access to medical care, a combination of social and economic inequalities is killing and maiming thousands every year, as most cases are diagnosed late, leading to poor recovery prospects. For instance, the Cancer Center at Kakamega County General Teaching and Referral Hospital only offers chemotherapy and palliative care. That means the facility, which attends to at least 40 to 50 patients per day drawn from the county and its environs, is often forced to refer patients to the Moi Teaching and Referral Hospital in Eldoret for radiotherapy services.
The cancer facility is still very small. It doesn't have enough machines to treat each and every cancer. The machines that are there are old, and therefore they are not able to cope with the number of patients that that are there.
Most of our patients cannot afford to stay in Eldoret the much needed time for them to receive radiotherapy sessions. So most times you find patients not opting to go to Eldoret to get chemotherapy because of cost implications and the distance. Therefore, if we had a radiotherapy unit here in Kakamega, I know we would do our best to our patients.
Those patients are the unfortunate victims of a dream that never came to be, as Kenya, in an effort to ensure access to comprehensive cancer care, unveiled 5 regional cancer centers during President Uhuru Kenyatta's regime. These centers were to be fitted with high-tech equipment and were to be designed and resourced to offer comprehensive care. However, administrative failures continue to hamper the delivery of these crucial services in some of those regional centers. A fact-finding mission by the Parliamentary Health Committee early this year sought to establish the status of cancer care in preparation for the rollout of universal health coverage. To its dismay, it found out that only 3 out of the 5 regional cancer centers were fully operational, as explained by Nyeri Town Constituency Member of Parliament Duncan Madenge, who is a member of the committee.
The ones that are complete are the ones in Nakuru, Coast General Hospital, Garissa County Referral Hospital. The one in Kisii is under construction. It's about 52% complete. And the one in Nyeri is just offering basic chemotherapy services.
Similarly, the lawmaker says radiotherapy services had been interrupted at the Garissa and Mombasa facilities for about 3 months. The delay in servicing the machines was due to a standoff between the county and national governments on who should bear that cost. That standoff, we understand, was made worse by other historical factors, including the inherited challenges from the controversial Managed Equipment Services project.
These regional cancer care centers are largely financed in terms of consumables and maintenance and staffing from county government resources. And there is no way the cancer care center in Nyeri, even that this is just providing basic chemotherapy services, can afford to pay for chemotherapy for patients from Laikipia, Murang'a, Kirinyaga, Embu, Isiolo, Meru, Tharaka Nithi, which basically are the Mount Kenya region that are dependent in that center. Because the governor Nyeri will be more worried about the providing general care for his Nyeri County residents. If he feels that he has to finance services for the regional population, then the question of how much his health resources can go beyond the boundaries of the counties becomes a real challenge.
And while this persisted, patients in dire need of radiotherapy services from the counties and their environs bore the brunt of the delay.
The operation of the linear accelerator is such that it generates a lot of heat, and therefore it has a special cooling unit known as a chiller. That chiller had broken down, and 3 months down the line, it had not been replaced. In a nutshell, it means patients who had already started treatment had their treatment interrupted. And therefore, the next point of call for the patients from the northeastern Kenya region and the northern Kenya region was to troop to Nairobi. The scenario at the Kenyatta National Hospital and the Kenyatta University Teaching, Research and Referral Hospital is such that they are waiting queues that run up to 3, 4 months, 5 months waiting period. So for these patients from Garissa who are on treatment and the treatment was interrupted, it means even if they traveled to Nairobi, they were not able to access treatment that had already been ongoing. Unless, of course, they had money to pay for it privately, which is very expensive. By the time then they were able to clear the 3 months waiting period as a minimum at best, all the machine was repaired 2 months later in Garissa. The stage of their cancer had either accelerated. If it was stage 2, it had grown to stage 3. If it was stage 3, it had grown to stage 4. And I am sure a number of them had lost the battle.
On the flip side, the Nakuru County Regional Cancer Center has been offering services uninterrupted.
How many more patients to finish in treatment today?
It is possible that, in this maze of financial and management difficulties across the country, Nakuru is reaping the benefits of prioritizing expenditure on healthcare. But even if that were to be the case, the shareable revenue allocations are not always equal across the counties. And this disparity leaves counties like Garissa and Mombasa disadvantaged compared to their Nakuru counterpart.
When we began, I remember the first day we had a clinic where we had 10 patients. Right now, every day we have on average about 30 to 40 patients coming to the center. We're able to give on average around 15 to 20 chemos daily. We're able to give radiotherapy to patients. Right now, one machine is fully operational. We give per session, we have about 45 to 50 patients on radiotherapy. That tells you the workload has greatly increased because people are able to refer patients. I think the question many people ask is there a lot of cancer now? Or why is so much cancer? So for me, I believe it's very possible that cancer always existed, but we were not diagnosing it. Many patients maybe died and we thought it was pneumonia, we thought it was maybe other infective processes because imaging modalities like CT scans, MRI were not really on the grassroots. People had to travel maybe to Nairobi, to Eldoret to get these basic services. So the fact that these services have come closer, it means we are doing more diagnosis. So you'll be able to.
And now, in a bid to ensure the regional cancer centers serve the purposes they were established for, the Parliamentary Health Committee is calling for revitalization, financing and operationalization of the National Cancer Management Institute, which was founded in 2012 to help coordinate cancer management in the country.
Cancer treatment is not sufficiently financed under the overall health care, and even the coordination of the equipment in terms of acquisition, in terms of maintenance, in terms of repair, and the provision of consumables, it is very erratic. But since the year 2012, we established the National Cancer Institute. And it is therefore the feeling of the Health Committee that we need to better coordinate, finance, and approach cancer care treatment under a specified, dedicated body for cancer care.
Through its National Cancer Control Strategy for the year 2023 to 2027, Kenya hopes to implement a coordinated and responsive cancer control framework that leads to reduced morbidity and mortality, and also improve the experiences and quality of life of patients living with the disease by the year 2028.
As a country, we have not really focused on screening, and I'm hoping as we go to think about going to having the community health promoters, I am hoping that that will really encourage us to have screening entrenched at the grassroots levels, so that if you're above the age of 40, then you need to have your mammogram done. If you're above the age of 45, you need to have a colonoscopy. We need to screen you for colon cancer. So we need to think about how we can incorporate screening in our treatment so that we are not just focusing on treating those who have, but we do screening so that we catch these lesions early. Because when we catch lesions early, then we are able to reduce the number of treatments a patient needs. So you might need just surgery. You get an operation and that's it. And you're cancer-free. But then when you present a bit later, then you find we have to combine majority of these treatments. And as we combine, it also increases the side effect profile for the patient. So screening really needs to be entrenched. It really needs to be put into our healthcare. And I'm happy the new insurance policy that's being talked about is saying that screening will be put in place. Because sometimes you see a patient, you know what they need, you send them for the screening, but since it's not catered for by insurance, they don't afford it. they don't do it, and only present when things have gone very far. So we're looking forward to a time the screening modalities would be incorporated and patients can be able to come and get screened and we can be able to manage them early.
Carry on with the treatment.
In what was at the time seen as a significant leap in technology and cancer treatment, Kenya launched the CyberKnife, a robotic radiotherapy procedure in October last year at the Kenyatta University Teaching, Referral and Research Hospital. This technology brought home significant advances in cancer care, especially in the treatment of tumors. It also added to the range of treatment and management options which have often been limited to chemotherapies, surgeries and radiotherapies. With its launch, Kenya became the second country in Africa after Egypt to boast the technology. But addressing the cancer scourge is not just simply a matter of providing appropriate equipment. There must be sufficient trained and knowledgeable staff on cancer management, and most importantly, the services must be accessible and affordable to patients they are expected to serve.
Good morning.
Decisive steps in putting an end to cancer's onslaught on humans, like the introduction of the new health laws in Kenya, is what the government is perhaps banking on to address cancer care gaps in the country. However, the fate of this approach hangs in the balance due to delays in mandatory registration under the Social Health Authority that was to commence on the 1st of March 2024. For Kenya, therefore, while efforts are being made to achieve cancer care equity, they are not enough. They are still not enough, and they are painfully slow for patients like Waititu and Mary. These efforts must move beyond the conceptualization stage, address the constraints of access to quality medical care and its costs, and in line with the three primary tiers of cancer care, which are prevention, diagnosis and treatment, these efforts must start saving lives by rolling out a comprehensive research, screening and diagnosis structure. Anything less than that would be a slap in the face for the helpless patients left to battle this debilitating disease alone. Gloria Milimu, KTN News.